They're good there. And then since it is 8:01, we will get started. I have some introductions, so hopefully that'll allow people to log on and join us this evening. Thank you for joining us, logging on to our next bite-sized learning session. I'm Caitlin McGuffey, Director of Foundation and Strategic Programs at the Ohio Academy of Family Physicians. These best practice sharing sessions have been created for OAFP members and family physicians to connect and learn from one another. Amongst the chaos of this global pandemic, there's been so much pivoting and reassessing and changes that are being made for the good. So we hope that we are able to highlight a lot of those changes here. Tonight, we are joined by Dr. Hiten Patel, a very soon-to-be graduate of the Ohio State Family Medicine Residency Program, an upcoming ultrasound fellow. Dr. Patel served as a chief of his residency and will be sharing with us his journey of leading his peers during this pandemic. Real quick, before I turn it over, if you have questions or comments as Dr. Patel is sharing, please put those in the comments. If you're watching this in our live page from the live tab, you may have to switch over to our home feed to see those comments. Just as a reminder. We'll monitor the questions as we go along and address those with Dr. Patel as needed or at the end of the discussion. And also this is being recorded, so you can revisit here on our Facebook page. It'll also be on our YouTube page and on our webpage for bite-sized learning sessions. So with that, I will turn it over to Dr. Patel for our session tonight.
All right, so I'm going to go ahead and share my screen here. And all right, so welcome everyone. Thanks for joining us tonight, and thanks to the OAFP and Caitlin for setting these bite-sized sessions up. I think they're a fantastic way for us to stay connected during crises and moments like this. So I wanted to talk a little bit initially about residency and how it's impacted me and my peers and really the general resident community throughout coronavirus and our current public health pandemic. So I'll start off with that and then move on to some of the learning points that I had for myself, helping the program through this and being chief resident, but also just as a general physician, and use those learning points later on to discuss how we can apply what I learned or what we have learned to our current crisis that we're facing now. So I'll first start with residents being the first line workers in hospitals. And some of this information is mostly repeat and review information, but we know that now resident physicians and physicians in general are infected with coronavirus at higher rates. There's a study that was published in April of residents in New York City, and only 25% of programs responded, but it showed that about 364 resident physicians were either positive or presumptively positive for coronavirus infection. So that just shows the magnitude of how often resident physicians are getting infected. There's at the bottom right, there's a quote there from a residency program director who, when found out that one of his residents were infected, he went back to his office, closed the door, and started crying. So the point of these stories and the point of a lot of fear and confusion, especially with personal protective equipment, really isn't to point out faults within each hospital system, but it really points to the fact that everything was so new, and as trainees, this impacts us significantly because of the uncertainty of what's going on, but also the fear of what can happen. And so briefly, I wanted to discuss challenges just broadly across what the country that residents have felt. And then more specifically, I'll focus in on Ohio and what our program did. So first, the challenge, and this was more nationally. I think there was struggles with personal protective equipment. So masks, N95s, gowns, really, I've heard stories from physicians, residents throughout the country, and I've even read policies about PPE and going into a code room, for example, which is generally considered a aerosolizing procedure. What do you do if you don't have an N95 mask? And so a lot of programs and hospitals have had to come up with policies for that. And so being on the front line, resident physicians, especially those in the MICU and emergency room, and even family medicine residents who are serving in those departments, struggle with fears about having enough PPE and not. And that kind of correlates with the fear of being exposed and being ill, because we now know that the infectious dose that physicians receive is much higher, and the rates of infection are much higher in resident physicians and physicians in general. And so living in that constant fear just compounds, especially in the beginning of the pandemic when we didn't know enough about coronavirus. And I think more importantly, what's really happened, and this is broadly for all physicians, is when you're working in the hospital or the emergency room, you have that fear of bringing the virus home. And so every patient encounter you have, you're extra cautious and you're more cautious. When you come home, you're more cautious with the clothing that you have. And you worry that if you do get infected and you expose your children, then you'll feel guilty about that. And so the point about all these challenges and struggles are that they compound on the already challenging and difficult time that we resident physicians have with work hours, with research, with applying for fellowships, studying for boards, having time to take care of finances and stay fit and healthy. All of that compounds when you have a pandemic going on and you have these fears, and that can lead to higher rates of burnout and physicians, resident physicians in general, but also physicians. And so that's kind of the background. And this isn't specific to any program. It's just kind of the national field that I foresee based on what had happened. But I'm optimistic. So, despite all of that, I've been really inspired to see the call to action that residents and physicians and medical students have had because of this pandemic. It from what I have read, is similar to the HIV epidemic, where residents really stepped up and physicians really stepped up. And it's controversial whether or not medical students graduating early to help in New York and in high infection areas is good or not. But I think that it's inspiring to see that medical students are willing to do that, that they haven't even had a day as a resident, but they're willing to graduate early just to help out in times of need. And that makes me feel optimistic. There's also stories of residents and physicians who are going cross country to New York just to volunteer for a few weeks, just to help relieve the medical system there. And then specifically for family medicine and residency programs, there's lots of professional organizational support. So on the bottom left, you can see that each of the ACGME, ABFM, and AMA have all had statements that support residents and support residency education. So for example, the ACGME and AMA came out to support the continuation of resident work hour restrictions as well as supervision requirements. And then the ACGME and ABFM have also supported pauses on rotations as well as possible exceptions to the 1650 patient encounters that family medicine residents need to graduate, which is really important, because if you think about it, there's pressure for program directors to continue rotations, and a lot of programs thankfully have put pauses on rotations, but they feel that pressure because of that desire to have residents reach that 1650 so they can graduate and they can move on. But the exception that came out with the ABFM in March really helped alleviate some of those anxieties. And then the other component was the allowance of telehealth visits or telemedicine visits into that 1650, which really solved a lot of the issues that residency programs were having in terms of getting residents patient encounters. And so all of that makes me optimistic that there, despite all the fear and anxiety that's going on, our healthcare workforce is really in it together to fight this pandemic. So I'll talk specifically about our residency program and kind of the changes that we made and what we learned from that and what I learned from that helping with this process. So back in March, I think our first case in Ohio was March 9th. And March 10th, I remember an email chain that we were having back and forth within our residency program, asking questions about what happens if a resident gets sick, what will we do with our backup system, how are we going to run our inpatient service, what will happen with didactics. 3 days later, we met in person on Friday, right before the weekend, and we talked a little bit more in depth, and we made some concrete decisions, which I'll talk about here in a second. And about a week later is when we really started bumping up our department-wide introduction of telehealth. And this was the day after Governor DeWine announced that there may be a stay-at-home order, which occurred about two days later. And so the point I have in this slide is that really there's two lessons learned. So responding early and reacting early to a situation that can potentially have long-term and devastating consequences is important. So, and this is really by listening to public health experts, by listening to or seeing and learning what's happening in other areas of the world and the country, and responding really rapidly based on that. So being proactive and responding quickly were, I think, very important in our response to the pandemic within the residency program, but also within the health system as well. So to our residency program specifically, we made a lot of changes, and I felt like every day we were making more and more changes, and it was really hard even for me, who was seeing a lot of these changes occur from the back end, to keep up to date on them. And so I'll just go specifically over a few so that way everyone's kind of familiar with what happened, and then talk about a few learning pearls that I learned from it. So with our rotations specifically, a lot of our subspecialty rotations that were in outpatient subspecialty clinics like surgery or cardiology, or inpatient subspecialty rotations, unfortunately had to be held due to the lack of in-person visits happening after the stay-at-home order was in place. So what we ended up doing was we had a lot of our residents doing self-learning at home. And so this consisted of having them review podcasts, watch videos, do board review questions, and specific focused reading that was relevant to that rotation. And so we tried to have residents who were staying at home during these rotations, who were working from home, keep a log of what they did, so that way we could say that yes, they were doing something specific for this rotation and they were learning. And that just made sure that we were continuing our education despite residents not being on rotation for specific subspecialties rotations. One of the first things that we changed pretty quickly due to social distancing, and then also to continue our education, was to have our didactics move virtually on Zoom. And we did that pretty rapidly. And it went pretty seamless over the first couple of weeks. And we utilized Zoom pretty regularly. And I'll talk a little bit about it, what we did with clinic as well here. But we used it to check in, and our program coordinators were fantastic and had check-ins at noon pretty much every day. We utilized Zoom for game nights as residents. We utilized Zoom for meetings, and so it worked out really well to seamlessly transition to that. In terms of clinic, in our FPC family medicine clinic, we pretty quickly transitioned from clinic to in-person clinic to telephone and video visits, and I'll talk a little bit about that. And the scaffold we did that with was using Zoom as our precepting platform so that we had adequate supervision. But our residents also did a lot outside of just their normal requirements as residents. A lot of residents volunteered. So we had a handful of residents volunteer shifts in the ED to provide some support to the emergency medicine residents and faculty and nurse practitioners. Residents volunteered in our call center at OSU just to help out and to learn really how to triage patients who have coronavirus symptoms. And we had residents also help write advocacy letters for reimbursement, and to include reimbursement, because we're, of course, a system and a clinic that supports low socioeconomic status patients. And so that funding is certainly important in terms of reimbursement. On our inpatient rotations, we had socially distanced rounds. So on the bottom right there, you can see our team of University of Dayton graduates are attending there up front, and then two of our residents in the back. And so at some points, they utilized Zoom for rounding, but they also try to keep their distance socially. And then we developed backup systems. So we typically have a single backup system, but we ended up developing a double backup system in case multiple people got called in. We try to keep our residents really well informed in terms of who is getting, if anyone was out, if they would be up next. And we try to keep our residents keep the culture that if you do feel sick, or if you are concerned about being sick, please let us know and we'll have a conversation about that. Or if you are sick, definitely take that time off, because we value the public health side of it. And we have, fortunately, at our program, enough residents who can serve as backup. And so I think setting that culture really helped keep the honesty within our program and within our residents. And so I had a couple experiences in person within the ED and the inpatient service, but I wanted to reach out to a few of our residents to get their idea of what they went through. And so a couple of our interns responded in terms of their perspective, and they worked in the intensive care unit on the coronavirus ward. They also worked in the emergency room and on our inpatient ward. And so they described a situation where they had high spirits and kind of camaraderie, but there was always this sense of fear because of various things, because of concerns about PPE, about concerns about infection, like we talked about earlier. They also described challenges of not having patients' families at bedside and having to call family members and having to give bad news sometimes, but also having to make decisions over the phone and having to describe the situation over the phone, which can be challenging. but they were thankful that they had the opportunity to gain telemedicine skills, which they believed would be important in their future practice. And they also thought that it was rewarding to be able to provide patient education on coronavirus. So one of our residents actually described the situation as being cautiously optimistic, which I thought was a great way of describing what the situation we are in is. So I think really the takeaway was that there's lots of learning opportunities, and of course we need to work harder as residents and really take up in arms for what's going on currently, but also back in March and April. So for me, as serving as chief resident during this time and working with faculty and residents, I really learned a few things throughout the year, but more specifically over the last 2 months or so. The first lesson I learned is that, which I think all of these can be applied really to clinical practice, to practice management, to leadership just broadly. So the things that I learned, the first one was to listen to the experts, listen to the people that you work with, the relevant stakeholders. As a leader, your role is to understand the situation and to work for the people, make decisions for the people that you work for. And so throughout the entire pandemic, I and our team tried to listen as much as we could to our residents and to public health experts, and to really act based on those. There's also an idea, and this is the second thing that I think I learned. I'm taking the leadership class right now through our College of Public Health, and there's a thought about something called reflective action, which is not acting quickly, but also thinking about what you're doing. So thinking how it impacts the broader situation that you're in. So reflecting on what's going on and then acting on that quickly, as opposed to just trying to solve problems really rapidly without reflecting on the situation. But even with that being said, with a pandemic or with really the rapid nature of clinical care, we do need to make decisions quickly, and the situation really taught me that. Next thing I learned was to have succinct, frequent, and really effective communication. And so we're all very busy. We have lots of emails in going through our inbox. We have our personal lives. And so communication is important, so that way everyone's on the same page, but it's also important to make it short and frequent. So we did it every 2 to 4 days or so, tried to send a email out with all the changes. And I think that was really useful. Being proactive, of course, I think is one of the most important lessons as leaders. So trying to fix a problem before it even happens and trying to learn from the people that came before you within that situation is useful. Now with a pandemic, it's really challenging, but it goes back to the first couple points of what I think I learned was that listening to the experts and acting quickly helps you be proactive instead of reacting after it's too late. And then third, the last point is just to be innovative. So when a challenging situation arises, you have to be innovative and think outside the box and utilize resources such as technology. And so virtual precepting was something that we did, but we also utilized telemedicine. And so I think that when a challenge arises, you have to think outside the box. So I'll touch briefly on telemedicine and residency. And I know this was already discussed in a previous bite-size nugget, but I just really wanted to touch on this because this is something I'm passionate about. And so there was in January of this year, actually a article that was published within the AAFP. It was actually on the website that discussed that family medicine residents are not getting enough telehealth training. And that was prior to the pandemic. And there's not really a lot of data or literature on family medicine residents getting telemedicine or telehealth training. Prior to the pandemic, the ACGME and ABFM didn't count televisits to that 1650 requirement that residents need to graduate, and reimbursement was really sparse and spotty for telemedicine. And so one of the things that are potentially going to change now moving forward is both of these really, is potentially the change in the requirement of the 1650 and having telemedicine visits count towards that, and potentially reimbursement as well. And so what we did in our program was pretty quickly, within a matter of days, honestly, went from having in-person visits exclusively to having our residents doing telephone visits within that first week or so. And really within a couple of weeks and at 90% capacity of doing telemedicine, both with video visits and with telephone visits. And we also did some e-visits, which are intrinsically built into our EHR, which is Epic. Like I mentioned earlier, our preceptors were on Zoom, and we utilized the room feature within Zooms, and we had 8 residents. If 8 residents were on, we had half of them within one room and half of them within another room, with each room having a preceptor. And so it essentially served as a clinic office or clinic room where attendings could utilize the room and staff and precept with our residents. There was also within our clinic structures a doc of the day or resident who was there during that day who would see all the in-office visits that were urgently needed. And then we also developed algorithms for our prenatal patients and to avoid and reduce the amount of in-person contact that they had. So instead of having them come back every week or every 4 weeks, we had spaces within the return visits, and we did telemedicine visits in between. And then towards the end, over the last month and a half or so, we've also done virtual nuggets, which are short 20-minute sessions where we do teaching, but before every half day of clinic. And so really quickly, I wanted to talk about the benefits of telemedicine and telehealth. So I think that as I've done more telemedicine, and I hope to do more in my practice over this next coming year, and then hopefully beyond that as well, some of the benefits that I've seen are that they tremendously increase access for a lot of my patients and a lot of the patients that we have within the city of Columbus. What I mean by that is that I've had a lot lower no-show rate. Patients are able to answer the phone when they're at home or when they're at work. They don't have to schedule transportation or have someone drive them over or try to have childcare set up so that they can come to their appointment. And so the ability for them to get on the phone or get on a video visit platform and to have a visit anywhere they are really increases access for a lot of our patients who have challenges coming to the office. It also increases the access to subspecialty clinics, so e-consults, but also getting in telemedicine visits within subspecialists. And I think it really avoids delay in care. So for example, if someone's going to come into the doctor for an acute visit, they may not be able to come in today or tomorrow because of work issues or transportation. But if they're able to do telemedicine, they're able to come in schedules that same day. And overall, I think this leads to decreased costs on the system. Perhaps there's more, this is my thinking, but perhaps there's more effective analyses that are done to show that this may not be the case. But this is kind of my gestalt that it might be decreasing. The benefit to providers are that you can view the patient's home environment, and you can also save time by not having to check in the patient waiting, the patient getting roomed, et cetera, et cetera. So instead of spending 10 minutes of a 20-minute appointment, you're actually spending 15 to 20 minutes on the actual phone with the patient. And because of all of the above, potentially you're improving patient satisfaction. Now, of course, telemedicine can be applied to everything. It's not a modality to use for a lot of complaints that come into primary care, but it can be utilized for a large majority of potential patient complaints. And so this is really the crux of what I wanted to talk about telemedicine and telehealth. I think there's a large future for it within residency training, but also within future practice as well. And so the big thing is that we need a lot more training for residents and also physicians in terms of how to apply telehealth and telemedicine. So that means, how do you do specific physical exam maneuvers? How do you bill and how do you write notes for telemedicine? And how do you actually logistically conduct a good telemedicine appointment? So where do you position your screen? How long are you supposed to be on there? What types of things do you discuss? And when do you decide that patients need to come in? So all these things need to be reviewed and taught. And of course, they can be learned on the fly, but I think that this is something that should be structured and taught in residency programs. Also, reimbursement needs to be rediscussed. So family medicine really will be one of the pioneers for telemedicine, I think, moving forward, in addition to psychiatry. And so we need to be an active voice, I think, as residents, but also as physicians, in terms of determining the reimbursement moving forward. One area that I'm really interested in is utilizing patient portals and using questionnaires to really get a lot of the HPI questions for a patient who comes in for any type of visit, really. And so that way, by the time you're actually seeing the patient, you have a lot of the HPI questions. And so, for example, if someone's coming in for neck pain, you can send a questionnaire specifically for neck pain, get all of the symptoms that you need determined. So by the time you are ready to talk to them, you only have to ask a few clarifying questions. And for me, this gets to the idea that if you have 20 minutes in a patient room, if you are spending, or a virtual room, You spend about 10 to 15 minutes really asking questions to try to diagnose what's going on. Unfortunately, that only leaves 5 to 10 minutes at most to talk about the counseling and talk about the treatment and really to talk to the patient about lifestyle change. As opposed to the other way around, if you were to use a questionnaire, you have all of your HPI. It serves really kind of like a resident asking all the questions on an inpatient service. So you spend about 5 minutes asking clarifying questions, and then the rest of the 15 minutes during the visit you can spend counseling, which is true primary care. So I think technology will be useful in this sense. The other benefit of telehealth is it allows social workers, pharmacists, nutritionists, and our other staff within the office to utilize telemedicine to provide care and to provide care to our most vulnerable population. Of course, there is a concern that there's inequitable telemedicine care provided. So those who have the low socioeconomic status may not have access to telephones or may not have access to broadband internet to be able to do video visits. And this is a significant concern that needs to be addressed. But I think that after that barrier is overcome, there's certainly a lot of implementation benefits. And I won't go too much into the detail. There's a couple other points on here, but really the big one is that I think has a huge potential is to utilize AI in telehealth and to utilize the data that we have and to utilize facial recognition and nuances to be able to determine heart rate and potentially other factors. So there's a really cool area and between the intersection of AI and telehealth. And who knows what we'll be doing 20, 30 years down the road. And so, I could have stopped there 2 weeks ago when I had decided that I would help do this. I really was going to talk about just those two topics, but I think that I would have been remiss not to talk about what's going on in the world right now. I think that it's unfortunate that I didn't want to talk about this 2 weeks ago. It's not that, George Floyd was murdered 2 weeks ago. And I think that African Americans have been murdered and brutalized by the police, and racism has been a thing for hundreds of years. So to have something like this occur to make me want to talk about this, it's shaming to me. I wish I would have talked about this earlier. But I am, I'm really mobilized, and I'm happy to see that so many people, so many physicians are out advocating for this cause now. And I only wish this would have happened sooner. And so when I really thought about what I wanted to talk about, I was really looking to some of our ethical constructs and really things to see if there was something within the way medicine was built that would have explained equality. And so I looked to the Hippocratic Oath, and unfortunately, there was really no mention of equality. There was actually one line that talked about providing care to the free man and to slaves. And so the mention of slavery within our Hippocratic Oath, something that we say when we start medical school, when we graduate medical school, when we're in residency, when we're physicians, the mention of that word within that oath really describes the problem that we have even within our institutions of medicine that is based in inequality. So I'll start by saying that the White Coats for Black Lives movement is something that's incredible. And if you haven't seen it or heard about it, definitely Google it. The picture on the left is in front of the James the other day on Friday. And I'll just play this really quick video to show you how many people showed up. And it's really incredible to see that SNMA, which is a student organization at Ohio State, help set this up. Anybody who has seen this before is really pessimistic. Really does not want this to be another. And this was all across the country. This was all across Ohio, all the health systems, and so it was really great to see that solidarity. And so, I was reflecting back on last week, about a week after George Floyd was murdered. What if his video wasn't taken? What if Philando Castile's video wasn't taken? What if Eric Gardner's video wasn't taken? Would we still have had such a protest? And the question really isn't, would we have had it? It would have been, why haven't we had it? Unfortunately, so many of these crimes and injustices happen and they're not caught on video, and movements like this don't happen. But I think what I really question is, it's not just police brutality. Racism is an entire public health crisis that can be rooted in multiple different areas of our socioeconomic structure. So we don't have videos of African Americans being unemployed at 2 times higher rate than white Americans. We don't have videos that show that Caucasians have 6.7 times more wealth than African Americans on average. We don't have videos showing that the infant mortality rate is 2.3 times higher than it is in African American than Caucasians. The lack of having these videos doesn't mean that these aren't real problems, that these aren't something that should be advocated for. And not everyone's aware of these disparities, but that's our role as physicians to understand these disparities, to fight for these disparities, and to spread knowledge about these disparities. And so I won't go through every disparity. You can read them on the slide, but some of them are really disheartening. Of course, African Americans are 6 times more likely to be incarcerated. And even kids are 5 times more likely to be imprisoned. African American children, are 3 times more likely to be under the poverty line than white Americans. And so, as physicians, we are healers, we are medicine people. But in order to practice medicine, these disparities that you see on the right, the fact that African Americans are 2 times more likely to die from stroke, or 4 times more likely to have kidney failure, or 2 times more likely to die from coronavirus, they're not health disparities just in and of themselves isolated in a silo. They are really rooted in a lot of the socioeconomic disparities, a lot of the cultural racism that we have. And if we don't do anything about them, all of these will continue to grow. And in fact, I was listening to Bloomberg earlier today with my dad, and there's an idea that COVID-19 and coronavirus is going to really actually increase a lot of the socioeconomic inequalities that we have due to race. And so that unfortunately is something awful to think about. But what I really wanted to point out are the disparities are across the board. And so we should be advocating as physicians to abolish and get rid of all of these disparities and to fight racism. And so what I wanted to do, and this is the last slide, so what I wanted to do here was to talk about what I learned as a leader throughout this past year, and having that opportunity, I was fortunate. And the points that I talked about earlier, so to listen, to be proactive, to learn, and to act and do something, how that can be applied to the crisis that we have with racism. And so as physicians, like I mentioned, we aren't just doctors, we are really public health, at the forefront of public health. And in order to really have a meaningful impact on a patient's life and well-being, we need to address all aspects of their care, their psychological care, their socioeconomic care, and the cultural background which with all that lies. And so, first of all, I think we need to listen. Listen to our patients, listen to our African American colleagues, friends, and to activists, and even individual stories, and to try to understand, what has gone on and what will continue to go on unless we do something. I think we need to learn as physicians, but also as individuals, what these public health disparities are and where are they rooted in. They're not just health disparities, but they're socioeconomic disparities. We also need to learn about Black history. The United States was really founded, and the economic boom that we had was really based within the institution of slavery. And that's something that's not talked about enough, I think. There's also institutionalized racism that's occurred over hundreds of years, but even to this day is occurring. And so we need to be aware of this. And we need to be uncomfortable, unfortunately, and to read about this and learn about this and fight this. And we need to be aware of our own implicit biases, right? So that's something that I encourage everyone to do, to go to the Harvard Implicit Bias website and to see what implicit bias you have yourself. The podcast 1619, which is from the New York Times, is actually fantastic. I listened to it over the last week or so. It's from Nicole Hannah-Jones, and it really provides a good background on race and African American disparities in the South specifically. And there's, of course, tons and tons of books and articles and podcasts that you can listen to. And this NPR article here provides a good overview of that. And so really learn, educate yourself, so that way after you learn about what's going on, you're not angry, you're not frustrated. You're then mobilized to act and to want to do something. And so there's tons of ways to do this. Not everyone is going to go out and protest, because that may not be your thing. And so if it is, fantastic. I plan on doing that. Unfortunately, I haven't been able to do that over the last couple of days, but I really want to go over the next couple of days. And I think The other thing that you can do as a physician is, of course, donate to a specific cause, and there's plenty of causes you can find online. But you can volunteer your time, of course, in free clinics. But I think what the biggest thing you can do is as a physician, you have a voice, you have a platform, you have the ability to actually cause change within your community, but also within the greater structure of medicine. And so to use your platform to talk about racism, talk about disparities, advocate to your legislatures, and to do something about it, because to sit silently and to sit and be frustrated by this, but not to do anything is really not helping the problem at all. And so I'll get off my high horse and stop there. Of course, this is something that I'm passionate about now. So I am happy to answer any questions about anything that I talked about.
Sorry about that.
Okay.
I wasn't coming back on. Thank you so much, Dr. Patel, for sharing your journey and your valuable perspective in all of these different topics. I think it's very timely and really a great conversation to be had. I don't think we're seeing any questions quite yet, so we'll give it a few minutes here, and I will kick us off with one. I guess just kind of combining everything together, what's one piece of advice that you would give to this next generation of family medicine leaders, whether it's what they can do to impact these movements occurring, and or even kind of what they should do as they're heading into this pandemic and how things are now. Just some kind of lasting piece of advice that you'd want to leave them with.
Yeah, I think one thing that I've realized like over the last year or so is that, especially as family medicine trainees and medical students who are interested in family medicine, you can really do anything that you want in family medicine. You can be a proceduralist, you can work in the hospital, you can do advocacy. And so ask yourself what you're really passionate about, and really focus your time on that. But then also ask yourself what's going on in the world. And as family doctors, your patients are always going to ask you about what's, current events or current, pandemic in this case is of course and kind of an outlier, but they're always going to ask you about what's going on in the world. And so really immerse yourself into really the world, I guess, for lack of a better word, and to try to be a good representative of that to your patients, but also to your community. And so I guess at the bottom end of it is to find out what you're passionate about and engage within your community about what you're passionate about.
Absolutely. I think I do see one question here. With regards to telemedicine, are there any telehealth resources that you would recommend for learners, or is it really learn as you go at this point?
Yeah, so that's a great question. So there are a few that I would recommend. So one, and they're all mostly based on YouTube. So there is, I can't think of her name, but I will come back and comment later, but it's essentially an allergist. And if you go to the AAAI YouTube page, she's an allergist who's been doing telemedicine for quite some time. And she has a series of videos that talk about, one, how to conduct a telemedicine visit, how to have your background and surroundings, how to talk, how to do physical exam techniques over telemedicine. So that one was really beneficial. Again, I'll post kind of the link to the comments. There's another one from the American Academy of Neurology, AAN, that talks about how to do a neurologic exam over a telemedicine visit. So those are the two structured ones that I've seen so far. There is a textbook of telemedicine, which I just kind of briefly saw it when I was doing my survey a couple weeks ago. I can't tell you how good it is or not, but those are the two resources that I'd recommend. And then practice. So if you are doing telemedicine, practice with like a friend or family member in terms of like if you're going to do a back exam, which you can do a large portion of the back exam. Practice how you would hold the camera or what you'd ask the patient to do. Think about what you yourself would do if you're like looking in the throat or trying to look in someone's throat. So I had someone who was trying to have them look in the back of their throat. So I had to have a family member shine a light, and then the patient have to turn their phone backwards. And so there's lots of logistics associated with it. You have to be patient, but I would check those two resources out first.
Awesome. I think there's one on how, I think more around how you operate with Zoom. Is the patient on the line with you? Maybe any quick tips on Zoom?
Yeah, so we actually use a different platform called UpDocs for our video visit with our patients, and I actually also like using Doximity. So as physicians, you should have access to Doximity. And so the Zoom is actually separate. So we have our Zoom pulled up to Precept and to staff, and then separately on the side, either on our computer or on our phone, we do our telemedicine visits through UpDocs or Doximity. Doximity actually is one of my favorites because you can also call, you can use it to send faxes. So if you're at home working from home and you need to send an FMLA paperwork or a letter to a patient, you can fax it using the Doximity app. You can call patients with your office number as the number that you're using, but then you can also do video visits. And the feature that I really like from Doximity is you can nudge the patient. So if you send a video visit to them and it's like 8 minutes later and you're like, oh, they might not have seen it, you can hit the nudge button and that will actually call the patient and you can say, hey, I sent a link, can you get on? And then you hang up, and then when the patient gets on, it's within the app, you'll just see them. So yeah, I guess the question may have been if Zoom is used both for patient care and for precepting. So we use the two separate systems. I do know that WebEx allows for third-party additions. Specifically, we've used it for interpreter visits, or we're trying to use it for interpreter visits. So I think that platform might be a little bit better for that.
Interesting. Great. And I think a lot of resources like this we share on our website as well as the AFP too, as we hear and share those resources. I'm not seeing any additional questions at the moment, so I'm going to throw up this last PDF here just with our list of resources. There we go. Just some reminders to finish off our session here this evening. The AFP Everyone Project, great resources and tips and worksheets all around social determinants of health, so please be sure to check that out. If you've made any changes, maybe around telehealth or some of the things that Dr. Patel discussed tonight, that may be eligible for American Board of Family Medicine credit. So we've created a video on kind of the instructions on applying for that credit with their new self-directed pathway option. So if you have any questions on that or need help, feel free to reach out to me and I'd be happy to walk you through that. We have a COVID-19 webpage that stays updated, a Joy Among Chaos webpage with some webinars. CME is free on those all around wellness topics. And then of course our bite-sized learning sessions next week on June 14th at 8:00 p.m. Dr. Mary Krebs will be joining us talking a little bit about rural medicine and what she's navigating through these days. And then I think we've got sessions for the rest of June, so definitely be sure to check that page out. This will also be shared there, the session, as well as our past few. And if you have a best practice or story that you'd like to share on this platform, please let me know and we'd be happy to highlight you and share. And that. And I don't think we see any other questions here, so I will wrap this up. Thank you again, Dr. Patel, for sharing with us this evening. I hope everyone has a great week.